again, everybody, and welcome to the HHA Workgroup hosted by Superior Health Quality Alliance. I'm Christine Lamb, a Superior Health Quality Improvement Advisor. Superior Health is a regional quality improvement organization operating under the direction of the Centers for Medicare and Medicaid Services, or CMS. We provide no-cost support for healthcare organizations across the tri-state region. And I am joined today by colleagues Barb Link, Janelle Shear, and Lisa Gall. This work group provides an opportunity for HHAs across Michigan, Minnesota, and Wisconsin to connect, offer support, and share ideas and best practices. The format is open discussion, and important links will be entered into the chat. Please feel free to unmute and share how your organization tackles the topics we discuss. And you may also post comments or questions in the chat at any time. Our agenda today includes some introductions, a discussion on embedding value-based care, a report out from our Timeliness of Care campaign, and some announcements and future plans for the work group. So here we come to the introductions. If you don't mind, please share your name, title, organization, your state, and your favorite fall color today. And while our group here is doing that, I think I'm going to start with my colleagues and have them introduce themselves. So we'll begin with Barb.
Thanks, Christine. Hi, I'm Barb Link. I'm with Improve Health out of Michigan, which is a partner organization of Superior Health Quality Alliance. And my favorite color, I love orange. I think orange is very pretty. And when you see a pretty orange leaf, it makes me happy. Okay. Should I send it over to Janelle? I'll send it on to Janelle.
Okay. Hi, everybody. I'm Janelle Shear. I am based in Minnesota. My home organization is Stratus Health, also a partner with Superior Health. I'm trying to think of the name of this color. It's kind of like a golden yellow mustardy. You've probably seen it. I had a top yesterday I wore it. So that's my favorite color, and I'll turn it over to Lisa.
Morning, everyone. Lisa Gall from Stratus Health, also in Minnesota, and I'm in central Minnesota, part of Superior Health Quality Alliance, and my favorite fall color is rust. I love rust colors. I'm a fall color person all year round, so. And then I'm going to move it to Allie.
All right, thank you. My name is Allie Duran, and I am a contractor at Superior Health. I am actually a student at Western Michigan University, and so I'm in Michigan. My favorite fall color. Oh, I also, like Lisa, I love all fall colors. I really like the leaves that actually incorporate, like have a little bit of green, a little bit of yellow, a little bit of red, kind of all the different colors. I look for those leaves.
Wonderful, thank you. You guys, I'm just like, I got all these wonderful fall colors like in my mind now, and I have woods right outside my window working from home. And so yeah, just to let everybody else here know, I am based in Wisconsin. Home organization is Metastar. My favorite fall color, I think, is like when the leaves start turning, especially those that are turning yellow, you kind of get this lime greeny color, where there's still just that hint of green in there, but you can see that yellow coming out. Thanks for sharing, everybody. And yeah, if attendees, if you want to keep entering your information in chat, we'll move on to the next slide. So our topic today, embedding value-based care in home health. So just overarching value-based care is a model in which care is given to patients with a focus on patient outcomes, prioritizing interventions that help improve a patient's health and quality of life. So that is the shift from this volume-based care, which historically was based on the quantity of services and procedures that were performed. Some key aspects for embedding value-based care in home health include that patient-centered care, outcomes-based payments, integrated care coordination, use of technology, preventive care, and data-driven decision-making. And I'm just curious from the group here today, are some of these aspects ones that you're aware of, or are you more familiar with than others? Just some initial thoughts and feedback here as we're getting started.
I think pretty much, sorry, I'm Bala from Holland Hospital here in Michigan. Pretty much all of what you mentioned is part of VBP. We want to make a holistic change in the patient's life and also improve the value for the dollar that CMS spends on us. I can pretty much think about one at least in each and every subtopics very nicely put together that we have done.
Okay. We'll start by talking about that patient-centered care piece. So that's the healthcare model that focuses on the whole patient to ensure they receive personalized care, including emotional, social, and financial factors to improve their overall health. It involves patients in their care, which means listening to them, informing them, and considering their unique needs, values, and preferences, and then tailoring care plans to their specific needs to improve satisfaction and outcomes. It also involves treating patients with compassion, respect, and dignity. And we do have, I think everyone here today is familiar with Superior Health Call Us First Toolkit. As a reminder, we do have some diagnostic specific action plans that can be referenced there if anyone needs some of those. All right, any comments or questions on patient-centered care?
And Christine, this is Lisa. I will just add on the Call Us First, those toolkit, those specific action plans are diagnosis specific, and it can be used by home health agencies and patients and their caregivers, and really call out when it's appropriate for them to stay home, take care of things at home, maybe call their provider or home care, and then or when to go to the urgent care or ER. And I would encourage you all to really dig into those diagnosis specific stoplight tools in that toolkit.
I think we'll hand it over to Janelle here to talk about some outcomes-based payments.
All right, thank you, Christine. So first of all, I'm wondering how many of you have been in home health before 2016? If you would just like raise your hand or do an emoji or put it in chat like, yes, I was. I'm just kind of curious. So these would be the times when payment was different. Thanks, Michelle. I see your thumbs up. And Kay, yeah, I figured there'd be quite a few people that have been in home care for a while. So before 2016, all Medicare certified home health agencies, they were paid for the number of visits that were provided for patients. You did a visit, you got paid. It didn't really matter the outcome of the patients. You did the visit, you got paid. And so during this time, Medicare beneficiaries who qualified for home health care often received inadequate, uncoordinated care for their health conditions, and it resulted in more visits to the emergency room, more admissions to the hospital, more placements in a skilled nursing facility. So 2016 was the year that home health value-based purchasing program was rolled out as a pilot in 9 states. So we've been hearing about this for a few years. And the pilot in these 9 states, it was a trial to see if care and costs could be improved by this different way of this different payment system. And it turned out it was successful. So there were decreased unnecessary emergency room visits, patient mobility improved, and it reduced Medicare spending. So then, as we've been hearing about, in January of 2022, CMS expanded the home health value-based purchasing model to Medicare certified home health agencies in all 50 states. the District of Columbia, and also the U.S. territories. And the expanded model seeks to improve the quality and efficiency of home health care across the whole nation, to improve patient experience with their care, to strengthen their physical function, and address health issues before they require an emergency room visit. So the pilot model was meant to improve quality and decrease cost. This expanded model, where everybody is a part of, aims to improve patient experience. I love that part. They're looking at the patient experience when we think of patient-centered care. Also to improve patient outcomes and to decrease costs. So home health agencies are now being rewarded for providing high-quality care with improved patient outcomes. And this is the shift we have to value-based payment. Who's
Anyone have any-
excited about this? I mean, the part I love the most is the patient experience, that we're actually caring not just about outcomes, but what is the patient experience? So if you put yourself into the patient's shoes.
And I wonder how many of you are really targeting those home health CAPS scores, the questions in your care delivery, so that you can capture a lot of that experience, that patient experience. So what do you all do to kind of keep a pulse on that?
Oh my God, HH caps is one of those things. Sometimes the numbers don't really proportionate to the ratings that we receive. We get excellent comments, very specialized care, but I think it's more of the 8 is the maximum I'm gonna give for anybody kind of an attitude is what we are dealing with. We are hospital-based agencies. So we have seen this in HCAPS also, which is hospital CAPS score. We try, our UPT team and other QAPIO teams regularly work on it, try to evolve ourselves more into changing ourselves more than trying to change the patient responses. It has provided some good results, consistent, but very slow.
Thank you for sharing that.
Hi, this is Kay Rennie from Henry Ford Health. So we do what we call first impression calls. So within the first week to 10 days, we call the patient and ask them how we're doing, and we ask questions around those HCAPS questions. Did the nurse or the therapist, whoever did the start of care, talk to you about all of your medications? Do you have questions about your medications? We ask, this isn't an HCAPS, but we asked, did the clinician cleanse their hands every time they came into your home, either with soap and water or with a hand gel? I don't have it in front of me to remember all the questions, but we do that. Also with the nurses, educating them, and I see somebody else had put using keywords. So we have the nurses ask about pain, about breathing, about the meds. Again, you can't, we ask that, we say to them at the end of the first impression call that we hope that their experience with us is favorable, so that if somebody they knew needed home care, that they would refer Henry Ford Home Health Care. And if there's ever a time where they didn't feel they could do that, if they would call the office and let us know, because that's the only way we learn, of what we aren't doing. Because of course, our perspective is we're providing that value-based care, but it could be a situation where we're talking Greek and the patient talks English. Do you know what I'm saying? So we review with the staff to review key items with the patient on a regular basis when it's appropriate within the visit. You know, some visits are very focused on a specific task or situation, and so we're not gonna, well, how are you feeling about your meds, you know, so that's what they do. That's what we do here at Henry Ford.
Yeah, I'm curious, Kay, like, is there also some opportunity in those conversations for that, using that teach back method, like asking them to kind of repeat back, or what questions they have, or do they understand?
Are you talking about on the first impression calls or at the clinician visits?
At the visits, or even,
Oh,
I mean,
yeah.
yeah.
Always,
Mhm.
always, yeah. They're encouraged to, you know, and then we talk about at orientation, motivational interviewing, always bringing the patient back to their stated goal. So, for instance, you know, they're not taking their diuretic because it makes them go to the bathroom so much. But their stated goal is, you know, generally I see pretty regularly, they don't want to go back to the hospital. They want to get stronger, or they want to go to some family event, right? So we talk to the clinicians about bringing them back to that. So they're not taking their diuretic because it's making them get up and go to the bathroom too much. Okay. You know, bring them back. You said that you told me when I first came out here that you wanted to stay out of the hospital. Well, if you don't take your Lasix or whatever, there's a higher chance you might go back to the hospital. So let's figure this out. But, you know, and maybe it's, if they have to take it twice a day, having it taken earlier in the afternoon, you know, with the doctor's permission and that. So, yeah, but always teach back, always asking them.
Yeah, that was a great example, Kay. Thank you for sharing.
Mhm.
We've got a lengthy comment here from Karen in the chat. In the last 2 months of care, they asked, did you take any new medication or any new prescription medication, or change any of the medicines you were taking? And in the last 2 months, did home health providers from this agency talk with you about the purpose for taking your new or changed prescription medications? And then some potential scripting. Her organization always wants to be sure that they know the purpose of each medication that they're taking. And then another topic here she shared, in the last 2 months of care, did home health providers from this agency talk with you about when to take these medications? Some potential scripting might be, let's talk about when you take your medications, when are you currently taking your medications, and giving feedback as to whether this timing is appropriate or not. And then a third here, in the last 2 months of care, did home health providers from this agency talk with you about the side effects of medication, or of the medication? Some potential scripting could be, as we review your medications, we always want to be sure you know potential side effects and what to watch out for. That's really great, Karen. Yeah. Thank you for sharing that. I mean, and that's always tough too with the HHCAPS questions, but these are really great shares.
Hi, I have a more of a general question regarding the value-based care model, if that's okay.
Sure.
Okay, great. My name's Nate. I'm with Maxim Healthcare Services. We're a nationwide home care provider, and I'm from our Madison, Wisconsin location. We cover all of Wisconsin, but so we're Medicare certified, but we specialize in private duty nursing, so long-term chronic care. I don't know, do we have any information of like whether this value-based care model might go to that side of like home care, the more chronic, long-term private duty nursing side of things, or just this more traditional home health model?
So
That's
I
a great
think,
question. And if you don't mind, I'll jump in. I have
Go
not
ahead.
seen anything with private duty nursing affected by that. Janelle, have you, and you've been looking through things?
No, I think this Medicare CMS, it's
Yeah.
for their payment
Fee for
program.
service, Medicare, home care, traditional services.
Yeah, I would agree with you, Lisa and Janelle. And thanks for that question, Nate. Right now, the payment model we have here is for HHAs. Of course, they have payment models for SNFs and hospitals, but yeah, I haven't heard anything either.
How about, has anybody heard anything about insurance plans going towards something similar? Because it seems like oftentimes CMS makes a change and then the plans follow. You know, so like your Blue Crosses or whoever, so it'd be people that don't have Medicare coverage, but they maybe are using home health under an insurance plan. Has anybody heard anything there?
No, other than knowing that where Medicare goes, other payers follow is kind of the mantra, and it may happen.
All right, wish we had more for you. But that truly was a really, really great question. If anyone is aware of anything that could help Nate, please feel free to put it in the chat.
I see Karen wrote a question.
Oh. On a webinar with reputable home health leaders, they were told that clinicians could ask if the patient would give them a 10 for the visit. They said that is different than the survey question of 1 through 10 for the agency. And she was not sure if that would be okay. So
I don't think you can do that.
yeah, I don't think so either, Kay, because I mean, thanks for the question, Karen, because I feel like it's then leading into the fact that they might get a survey. Is that, I mean, it's kind of the.
I know we had discussion around that because, you know, it was brought up. Somebody had bought a car, and when they were picking the car up and leaving the dealership, the person who was showing them, you know, the different gadgets in the car had said, if you get a survey, would you be able to give me a 10? What am I missing, or something like that? And so even though you're not saying you're going to get a survey, it's like you're not giving them the whole story. Do you know what I'm saying? So anyway, we were told that no, you could not ask for a rating. So that's why, like on our first impression call, we say, if there's ever a time you don't think we're doing the best job, can you let us know?
Yeah, I think it's a really a fine line to ask that question. I mean, I wonder if it could be worded a little bit differently to say, have I answered all your questions? Or how, you know, how would you say my service was for you today? Or, you know, whatever the topic was, you know, would you say that it was satisfactory, or that I gave, like, it was excellent? I think you can rework it and reword it to not include that number 10.
Yeah, I agree. You would never want a patient to feel pressured or feel, you know, I think there are just a lot of things, even if it's kind of okay to do, that you just wouldn't want them to feel a certain way. That's so funny because I had the same thing happen recently when we purchased a car. And I thought, you know, I'm still going to rate you the way I feel like I should rate you. But, you know, if it was my health, would I start saying, oh, am I not going to get great care if I don't give you a 10? Or, you know, I feel like patients could feel compromised. I don't like that wording. So that makes sense. And I'm glad you asked the question, Karen, because I think it's a some people might feel okay with that, but I don't, yeah. I haven't seen any, I'm sure I haven't seen any guidelines or anything that says you can't ask the question that way, but do you, like, for good work practices and ethics, would you want to do that? Probably not.
Great discussion, everybody. Let's slide it on over to integrated care coordination with Barb.
Yeah. So just sort of covering this at a high level, just, there are a lot of different definitions of care transitions, but thinking about it as the movement of a patient from one healthcare provider or setting of care to another one. And I think we all know that a lot of things can happen with poor communication and not having that seamless care transition for the patient care and the importance of that. So really thinking of some of the goals of effective care transitions to really improve the patient experience, getting back to some of the things that Janelle talked about, and how do you mitigate some of those risks for adverse events. I think Karen put some great things in there about medication errors and how to make sure those don't happen. That can even transition over to helping the patient advocate for themselves as they're transitioning in their care, as well as handing off to another level of care. Thinking about falls that could happen without a good transition of care, emergency room usage and readmissions go up, all these things we know about. But really thinking about when you're looking at your measures, what are some of those things that you can really reduce? And again, it's always adverse drug events, thinking about how that communication happens with the patient, the family, moving from that next level of care. Interpretations of the care that you're providing to the patient and making sure that people know about that from the family perspective, patient perspective, and from your perspective, handing that over to the other level of care, or when you're receiving someone, say, from the hospital or a SNF level of care. And then really trying to increase that patient engagement, because really they're the ones who know their situation. And as you can see in the graphic there, they're really at the center of that interdisciplinary team that you want to really include in all care transitions as much as possible. And really thinking of all those different people, like, pharmacists have really increased and their knowledge of drug interactions and how they've even had some innovative programs from hospital to home where they're involving pharmacists now with med reconciliation, thinking of the nurse practitioner, hospice care nurse, trying to involve everybody in really doing a thorough analysis of who needs to be on that care team to make sure that those transitions go really well. And then also the promotion of the SBAR. And I'm sure a lot of people use SBARs in their recording and that sort of thing. But this is a nice review of it here, looking at the situation, your role, the patient's name, their demographic information, primary reason for communication, looking at their background, recent and concise summary of their diagnosis, looking at, of course, current medications, allergies, recent labs, all the med orders. Then the assessment is in there, be it brief, but make sure that it's talking about the patient's condition and what you think the problem is, and then the recommendations there. And I guess to me, I think other people have talked about best practices, and I think they all really talk about this in your transitions of care too. Like Kay talked about motivational interviewing and how that can really be used as a way to engage the patient, make sure that they're understanding what their situation is, talking about some of the issues they may be having. It can be a really great technique to use to engage a patient quickly. But I think Bala talked about that they're finding that things just take more time. But interestingly enough, I just went to another motivational interviewing webinar the other day, and they talked about, even though some of this is, as we always talk about, front loading, when you're front loading something with motivational interviewing techniques or talking to the patient more honestly, more down the line, like I think that that's a great idea Kay, about those follow-up calls that you make with the patients, because I think all of those things on the other end, when you're looking to discharge or really making sure that the family understands the situation and you're teaching them and the patient, that those smooth transitions of care might take more time with all of this in the beginning. But I bet you're finding over time that really it's shortening some of those things, and readmissions aren't happening, ED use isn't happening because you did all of those things that might have taken a little bit more time on the front end. So that's just the high level overview of how care transitions are incorporated in HH. The value-based purchasing. There's a great link here to a more detailed slide presentation, which even has more links onto some great resources too. But I was just wondering again too, as everyone else has asked, you found that this ends up taking more time now than it used to, or are you finding that care transitions are a little bit more seamless now, or are they still challenging?
So Barb, this is Kay again. I think they're more challenging because patients are sicker. I mean, I cannot believe, I do a lot of chart review for patients who are readmitted, or patients that are readmitted, and it's just, I cannot believe how sick people are, how young they are and how sick they are. How many, the multiple comorbidities, the lack of support in the home, the social determinants of health. If somebody goes back into the hospital within the first 5 days, it's probably diagnoses related. But if somebody's going back in the hospital, after 2 weeks, it's probably something to do with some social determinants of health. And so trying to identify those and address those. I'm always telling our clinicians, get the social worker in there, because the social worker, there's they seem to have a list of endless resources.
Yeah.
And so it makes a difference. But every day I cannot believe how sick people are.
Yeah.
That's interesting, Kay, that you're mentioning that. We did here at Superior Health, we had another group that we did a collaborative with, a community health improvement collaborative. And one of the challenges they were seeing was that access to those
Yes.
community supports and services.
Yes.
So I think, yeah, that is a big piece of it as well.
Yeah.
For patients who qualify for caregiver support through their insurance or something, so I've been on huddles and they don't have help in the home. And so if they don't have help in the home, they're trying to set them up with getting groceries delivered, different things like that. But if they don't have access, it just,
I think, Kay, that's a great point. And, I was just at the Minnesota Home Care Association annual meeting, and there were a couple of ambulance services that provide community paramedics. And I'm sure, you've all heard of community paramedics. And what the concern was from home care is that, oh my gosh, you're going to take our jobs. You don't need to do all this charting. We need to do it all. But in reality, they're allowing us to do our jobs better if they're in the home. And what they're doing is picking up some of that slack that is missing, going and doing some meal prep, doing some of those duties that this person cannot do because they're so sick and they're unable to go shopping and to cook and to clean their home and make it safe. And so these paramedics, community paramedics and community programs, and like Christine mentioned, the Community Health Improvement Collaborative has a lot of resources in how to get involved with a community level organization so that you can find out, like you said, through the social workers. I've found that sometimes social workers don't even know what's in their communities. With my mom, they did not even know there were assisted livings 2 blocks down the road. So I wouldn't rely completely on, not that I'm not trusting social workers
well,
by any means.
I'm going to do a shout out for our social workers. I've been with Henry Ford since 2010, and I get on a huddle and there's a resource specific for a patient. And on the side, I'll say, how long has that been around? Or when did you find out? And it's been around for years, or so I have complete faith in our
Great.
social workers.
Great, because you
Well,
need someone who knows what your community involves and that the
yeah.
patient's community has
Yeah.
in place.
And there are some really interesting things going on with CMS regarding, because they do see that patients' health is connected to their social drivers of health or social determinants of health. And, it's interesting because I'm a social worker. Thank you, Kay, for the shout out, because it's a tough job. And I think the other thing is that I have this background in information and referral. Some people say, oh, you can just go on 211 or you can just do. I think it is a very skilled job, and it is hard to know how to categorize and know what's out there in the world. And there are specialists in information referral. Sometimes it's social workers, sometimes it's care managers, it's a lot of different things. But it can really be a full-time job to really know what's out there, who has a waiting list. And a lot of these community organizations are really dependent on external funding and grants and things like that. And so I think CMS is finally understanding that they're developing these community care hubs where organizations are trying to come together, streamline the processes, figure out ways that funding can be like centralized for all the different, it's been kind of a fragmented world here. And it's really coming to light that these people, they do great work. They need to have supplemental funding, and it needs to be kind of coordinated. And there are deserts of services in, rural communities, even sometimes in urban communities, if you can't get to a service. So, I think there is a movement to coordinating that care. And a lot of times, somebody's health is suffering because they aren't getting proper nutrition or able to access their appointments. And I I think, as you say, as people are getting discharged home sicker, or there isn't that support system like there used to be, we really need to move towards a coordination of care for people. And it is, to me, I think, an art form for that as well. So, yeah, some very interesting things going on in that world right now. So,
Kay and everyone for that great discussion on care transition. All right, now we'll talk about use of technology. So HHAs can implement technology like telehealth and remote monitoring devices to answer or enhance care delivery by tracking patient progress and intervening when an undesirable result is received. And I think, at least in the group here today, I think some of you already use some of these devices or these remote patient monitoring, such as the blood pressure monitor for treatment of hypertension, the weight scale to monitor some health statuses like heart conditions and some weight management needs, blood glucose monitors that help patients with diabetes, and the pulse oximeter, which can detect oxygen changes and help manage multiple conditions. A few of those are listed here. And I mean, I'd be curious to see how many of you are using some of these devices. But first, I wanted to mention, I do mention telehealth a little bit lightly. Also would be interested to hear if any of you are using telehealth services and how easy they may have been to implement. Knowing that right now, I believe it's covered by Medicare Part B. There was an extension with COVID through 2024, so there might be some changes coming down the pike from CMS in that realm. But again, curious who might be using some devices. Are you finding them easy and valuable? And then, is anyone using telehealth?
I'll kick this off. For Maxim Healthcare, again, we specialize in really high acuity patients in that private duty nursing. So we'd use all of the above quite a bit in the home for our patients. Don't do any of the telehealth, however.
And this is Kay again from Henry Ford. And we use all of that. And we do use telehealth with some of our programs. We have a physician that will provide a virtual visit. It's a program that, you know, as many of the home care providers know, when a patient is discharged from the hospital and they are of a certain acuity and have certain diagnoses, and so they're stable enough to be discharged, but not stable at, you know, not totally stable at home. And until they see that specialist or the PCP, if something comes up and you call, they say, send them back to the ER. And so we have a program for patients that require a little closer than close monitoring, if that makes any sense. And we will arrange a virtual visit with a PCP who will bridge that time. So the time between discharge and follow up with their PCP or specialist, we'll do a telehealth visit. And then if there is some instability, the nurse can access the doctor, halos the doctor, sends a message, the doctor calls, and we'll make med adjustments. And so we've been successful in that program of keeping people out of the hospital and out of the ER. We're trying to expand on that, but, you know, just like there's access to community providers, there's difficulty in access in medical providers too. So we're looking at, currently, like I said, we have a few doctors that we work with, but making that even a bigger program because we've already shown that it is effective.
Yeah, thanks, Kate. I'm really hoping the coverage for telehealth within home health doesn't see a ton of changes because it is being covered now in that home setting, if you will.
Mm-hmm.
So yeah, I'm really, really glad that you're able to utilize that and agree. It is still difficult to find providers to deliver that service as well. And also good to hear that these the RPMs are popular within home health agencies. So, all right, let's talk about some preventive care. I think we're all super familiar with what preventive care is and that it focuses on early interventions to help reduce readmissions and health-related complications, which can include conducting home safety and fall risk assessments, educating patients about healthy habits, and administering vaccines. And again, here, Superior Health Call Us First Toolkit also has some diagnosis-specific tools that you can reference. And I don't think we need to spend a lot of time here, but if anyone has a comment or question, we can pause for a moment. So the final aspect that we wanted to highlight today is data-driven decision-making. And this is a little bit similar to how remote patient monitoring devices are used to collect and monitor patient conditions, where data-driven decision-making leverages analytics to identify trends in a patient's condition. This approach also provides a quick visual of the overall health improvements and can highlight areas of concern. For care providers and patients, visualizing those health patterns can sometimes be easier, and you'll see like in the picture here, not that you would have this big screen like this in a patient's home, but as an example of if you have the capability to display some of these things for patients, it might be easier to have that visual. And also if a patient has some specific goals, you can also have like a goal line that can be included on those graphs to help track that progress and say, hey, you're above your line, or we're almost there, to have those very interactive conversations with them. And then internally, some analytical graphs and charts, or sometimes they're called dashboards, can be created to quickly identify high-risk patients. So I know sometimes the capabilities for doing analytics on this level are a bit of a challenge, but hopefully these are some things, or hopefully you have the capability in your organizations to do some analytics and share that visual outcome with patients. So again, it's so much better than a snapshot in time where you can show some trend lines on how that patient is doing and how things are being monitored and cared for. Any questions or comments on data-driven decision-making?
I'll just put one plug in for stratifying that data. So that you're hitting the equity lens in providing care to those who have, racial or, any other disparity that could impact their health.
Okay, we're gonna now hand it over to Lisa and Allie for an update or report out on our Timeliness of Care campaign. Take it away, ladies.
All right. Thanks. Thanks, Christine. The Timeliness of Care campaign is actually developed by this work group as a scripting tool that is meant to be used for home health agencies as they get referrals and use a scripting tool to cover. And we have about 6 points in there that they can cover. And we have asked Allie to reach out to some of our participants and non-participating participating home health agencies across Minnesota, Michigan, and Wisconsin to see if they are using any type of a scripting tool, even if it's not this particular scripting tool. And I will let Allie report on that, but I'm just giving a little bit of overview of this. And then in addition to that, we have the home care acceptance tracking tool. The whole purpose of the scripting tool was to improve the acceptance rate of home care services to decrease potential risks for hospital rehospitalization, readmissions, and ED utilization. And so the Timeliness of Care campaign was to initiate services within is it 72 hours? Is that right? So that patients don't have a delay in the start of their care services at home, because it has been shown in studies that early intervention from hospital discharge and early transitions of care and services are impacting patient outcomes and readmissions to care. So we have the home care acceptance tracking tool is an Excel tool that is a little complicated looking and complex looking at first glance, but it actually only asks like 2 questions. Did the patient accept a few questions? Did the patient accept care? Did you use a scripting tool? Yes or no? And then it automatically calculates some of the responses from the intake worker. We have had a couple of home health agencies across the region that have been shown interest in doing the scripting tool, comparing it to theirs, and using the tracking tool. However, I think everyone's issue, and Allie will speak more to that, is time and using a tracking tool when they may already have something within their EHR. However, the acceptance tracking tool can get to some root cause analysis. So Allie, I'm going to hand it over to you to take it away.
Great. Thank you, Lisa. And also thank you for everyone who I've spoken with that might be on this call, who has taken the time to give me a little bit more information about your agency and your intake process. So I've had an opportunity to email back and forth with some agencies across the region and provide feedback on the scripts that they're using currently, and kind of compare that to the script that Superior Health has developed. And I've also given some insight on how the Superior Health script is designed. And like Lisa said, it's 6 core components that are beneficial. And so as all of you are aware, every agency is very different in how they accept referrals and the process that they use to gather information to set up that initial home visit. And so as I reflect on the conversations that I've had with many of the agencies in the region, each agency has similar but sort of nuanced challenges and barriers that they face. So I'm hopeful that the script that Superior Health has developed has allowed for some constructive conversations and has been helpful to point out some of those key components to include in an intake call. yeah, overall, as again, Lisa touched on, there some barriers were lack of time, and I've sort of helped support some agencies in looking at the process that they currently use and figuring out how to mainstream some of those processes. I think overall the project in general has definitely shed light on that intake process and given that more attention. And we are able to give more information to agencies on how they can make some of those beneficial changes. And so for the agencies that I did collaborate with, we certainly made some progress, and I hope I was able to be helpful and supportive to them. So thank you again for allowing me to join and provide the update, and hopefully be supportive in some way.
Thank you, Allie, and we definitely appreciate all your work you have done on this project. It was such a pleasure working with you on this campaign.
Yes, same for me. So thank you.
All right, now on to some exciting updates and future plans. Superior Health is currently wrapping up our current 5-year cycle of work on behalf of CMS, and we're excited to share some of these updates with you. New Quinn QIO goals, so that would be Superior Health as a Quinn QIO, and opportunities coming our way. CMS is soon to introduce some new goals and opportunities for Quinn QIO, the Quinn QIO program. If anyone is interested in checking out Superior Health final report for all the work, or for some highlights and accomplishments that we've achieved since 2019, we have that link here. I'm going to send that. There we go. The link to the slides today I just put in chat. And we also wanted to give an update that Superior Health has posted some information about their planning for this upcoming CMS cycle of work on our website. If you're interested, you can view it there. And then what this means for our work group is that we will be pausing the work group for now. And then at least for the remainder of this year, some early next year, we'll be sending out some emails to reconvene the work group. In the meantime, you can check out our new website if you haven't already, new and improved, and it features a fresh visual look and some updated navigation. We also have a new resource library that has not only Superior Health resources, but from other organizations that we've talked about throughout these work groups that you can find there as well, organized by care setting and topic, and is searchable by keywords. So you will see in there care setting, there is a setting for home health agencies that you can select. And of course, a lot of the materials, even if they're for a hospital or a SNF, you might find something that's useful in there for home health agencies as well. So you can check those out while you're waiting for our email. And then we also wanted to let everyone know that there are some upcoming tobacco cessation on demand. We're calling them quickeners, which is kind of a fun word. So some bite-sized learning modules that can help when you're working with individuals who might be on their journey to becoming smoke-free. And then each session is 5 to 8 minutes. Now, we don't have the link available yet. We are expecting that here within the next couple of weeks, and they will be in that new resource library that we just talked about on the previous slide. So if you click that link, they should be there soon if you're interested. And then we thank you for the discussion and for joining us today. If you have any questions, you can contact any one of us listed on this slide. And then we have about 2 minutes left. If anyone has any final comments or questions, I'll take a brief pause here for that. Okay, hearing none, thanks again for joining us, and we will see you in the new year. Thanks, everyone.